Hello, everybody. It's a great pleasure for Nijsje Dorman, Stacy Christiansen, and Andy Levey and myself to welcome everybody to today's webinar, which intends to summarize the rationale and the outcomes of a KDIGO conference that was held in Amsterdam almost exactly a year ago. The focus on this conference was on nomenclature. Now, why should KDIGO focus on nomenclature? Our primary goal is, of course, to improve health outcomes, but this process, with diagnosis, classification, and therapy being essential components, does also depend on communication, and communication requires nomenclature. Nephrology has for a long time not done very well with respect to a uniform and precise language. In this article by Dr. Scherter and Dr. Su, they actually coined the term chronic renal confusion to indicate that we were unclear in our language about how to describe impaired kidney function. This was published in 2000, and obviously much has improved since then, much progress occurred, but there's still limited consistency, imprecision, and lack of patient-centeredness. A prime example which actually triggered the conference is the term end-stage kidney disease, which implies the final stage of an incurable disease rather than a state of disease that affects individuals who, despite all limitations, can survive for decades if they're properly treated. However, changing established nomenclature is a challenge, and it naturally meets some resistance. And this requires to involve all stakeholders, to achieve a consensus, and to liaise with those who take prime responsibility for the use of language in scientific journals, editors, and their editorial managers. Dr. Levey and I were fortunate that KDIGO enabled us to address this challenge and share this project together with two very experienced editorial managers, Nijsje Dorman and Stacy Christiansen. We were very pleased to assemble an outstanding group of experts of clinical scientists at this meeting, representing the editorial boards of most nephrology journals, as well as editorial teams of non-specialty journals, amongst them leading journals in the field of medicine, such as the New England Journal of Medicine, the Journal of the American Medical Association, and The Lancet. The acceptance of these people alone was already extremely rewarding and encouraging. Nevertheless, when we came together in Amsterdam, the outcome of the endeavor was unclear despite all the preparatory work that we invested. Failure was a real option, to be honest. If we would not have achieved consensus at this meeting, this would not only have been a missed opportunity, but it would have meant a backward step. We are extremely pleased today that the conference was not a failure, but a great success and resulted in true consensus. And by the way, why KDIGO has so deserves this name. Agreement and buy-in are obvious from the fact that the vast majority of conference participants agreed to be co-authors on the conference report, soon to be published in Kidney International. Moreover, in parallel to the publication of this report, approximately 25 journals have agreed to a parallel publication of editorial comments that highlight the main messages. We are not aware that an initiative of the international nephrology community has ever received a similar attention. On behalf of all four co-chairs of the meeting, I would like to take the opportunity to thank all those who made this possible. KDIGO leadership for their openness and courageousness to organize this meeting. All conference participants for their thoughtful contributions. Consistent and accurate, despite the variable editorial requirements of the different journals. And finally, I would also like to thank the sponsors of the conference who provided the necessary support, although the content was not related to any specific therapeutic area. With this, I would like to hand over to Dr. Levey and ask him to describe the proceedings at this conference and the outcomes in more detail. Let me also tell you that you're very welcome to ask questions, and we would like to ask you to formulate these questions already while the presentation is ongoing using the chat function of this meeting platform.
Thank you, Kai, and welcome to the webinar participants. We are in the midst of the coronavirus pandemic, particularly in Boston, and although the number of cases is waning, I'm still working from home, and so you'll see the background of our dining room here in Boston. And you may hear some street noise because they're always doing construction of some kind. I apologize in advance for any distractions or for a fidgety Wi-Fi connection. The goals for my presentation are to spend the next 20 to 25 minutes reviewing the rationale, although Dr. Eckardt has really covered that completely, the goals of the conference and the main questions to answer. I will do this a little bit like a book report in that I will tell you what happened at the conference as well as what's in the Kidney International Conference report that Dr. Eckardt showed you the title page. I'll have a couple of thoughts about nomenclature, about patient-centeredness, about precision. I will quickly review the KDIGO definitions and classifications that we will be using. I'll mention who are the speakers. I'll talk about the strengths and limitations of our effort, but then I will go through the glossary. The glossary is long, and so of course there are a lot of slides, and I won't be going through these slides in detail, and you'll be able to have these slides at the end of the webinar. We thought we would show this slide of the grammar police. I'm a little bit worried that you'll think of us as grammar police. Of course, it is the job of editors in scientific journals to be the grammar police, but we hope that we'll deal with the main concepts here rather than just the grammar. So why is uniform nomenclature important? Dr. Eckardt went over this. It's important for patients, and it's important for clinicians and health professionals. In fact, this is the virtual abstract for the KDIGO promotion of the nomenclature report. And here's the introduction to our report, and I won't read from it verbatim, but I will read this last sentence that says a coherent shared nomenclature could influence communication at all levels, including not only greater appreciation of the burden of disease, but improved understanding about how patients feel about their disease, more effective communication between kidney disease specialists and other clinicians, more straightforward comparison of integration of data sets, better recognition of gaps in knowledge for future research, and more comprehensive public health policies for acute and chronic kidney disease. So we really did have high goals for our effort. The guiding principles for the uniform nomenclature that we propose is that it should be patient-centered, meaning the wording should not be demoralizing or stigmatizing. It should be precise. The wording should foster accurate communication in clinical practice, research, and public health. And it should be consistent with the KDIGO guidelines. We propose adoption and definition of wording that's been formalized by KDIGO should aid in evidence-based practice and guideline implementation. So the goals of the conference, we've mentioned before, are to revise and refine the nomenclature to describe kidney function and disease. The principles is that they be patient-centered, precise, and consistent with the KDIGO guidelines. And we asked the conference participants to be prepared to agree or disagree with the following statements: that articles in the English language medical literature should generally use kidney rather than renal or nephro when referring to general aspects of kidney disease and kidney function. 2, kidney failure with appropriate descriptions of presence or absence of symptoms, signs, and treatment rather than end-stage disease. The KDIGO definition and classification of AKD and AKI rather than alternative descriptions to define and classify severity of AKD and AKI. The KDIGO definition and classification of CKD rather than alternative descriptions. And to use specific kidney measures such as albuminuria or decreased GFR rather than non-specific terms such as abnormal or reduced kidney function to describe alterations in kidney structure and function. And indeed, the conference participants did agree it really was a consensus conference, and that's reflected in the glossary. Now, Stacy Christiansen is the managing editor of the American Medical Association Manual of Style, and we were thrilled to have her participate in the conference. And she gave a presentation, and I want to let you know that I thought the most important thing is that the 11th edition will contain some wording about the KDIGO conference, but the 10th edition, which has just been supplanted by the 11th edition, contained no mention of approved or suggested kidney disease nomenclature. So we feel that we will have an advance already. Now, Stacy reminded us that nomenclature is defined as systematically formulated names for specific entities, and in the biomedical sciences has required ongoing work of international groups. The development of nomenclature requires convergence of multiple names into an accepted set of terms, meaning some users must be willing to relinquish traditional words that may be more familiar or memorable. Nomenclature must be consistent with current knowledge and stable enough to remain relevant for the foreseeable future, but sufficiently flexible to accommodate a new vocabulary arising within advances in the field. The new edition of the AMA manual we'll mention briefly because it came out right at the same time as the nomenclature conference, but it will mention that the following: that KDIGO is spearheading an international effort to revise the nomenclature. The effort will focus on making terminology more patient-centered and precise, and that the final recommendations and a complete glossary of related terms will be available after an international nomenclature conference in 2019. And we anticipate that there will be updates to the AMA manual with the implementation of our glossary. Now, we had a presentation by Allison Tong of the SONG initiative about patient and caregiver perspective on the definition of impact on terms to describe kidney health in an effort to teach us about what does patient-centeredness mean. Now, the National Health and Medicine Division of the U.S. National Academy of Sciences, formerly known as the Institute of Medicine, defines patient-centered care as providing care that is respectful of and responsive to individual patient preferences, needs, values, and ensuring that patient values guide all clinical decisions. I'll skip here. In principle, the terms used to describe kidney function and disease should be understandable to all, with acknowledgement of variation in the level of health literacy. Use of multiple terms with similar meaning can lead to confusion, as can use of terms that forecast the future, such as pre-dialysis, rather than describe the present. And Allison Tong will be publishing the results from the patient and caregiver focus groups, which describe these themes and these sub-themes in an upcoming issue of CJASN. Regarding the term precision, and the Precision Medicine Initiative of the National Institute of Health, we were pleased to have Dr. Matthias Kretzler give us a presentation. Precision has a general definition that's really known to all: the fact, condition, or quality of being precise, exactness, or accuracy. However, we have to appreciate that how medicine is defined and understood is changing rapidly, from a descriptive disease-based categorization in which multiple pathogenic pathways may be conflated to a mechanism-based categorization that will promote more precise management of clinical problems. The latter approach, in which a molecular profile is added to clinical and morphologic profile, has already revolutionized diagnosis and treatment in oncology. As has occurred in oncology, we anticipate that refinements that result in more precise disease descriptions will be incorporated into current nomenclature for kidney function and disease rather than replace it together. So we feel that our effort is completely aligned with the goals of precision medicine. Nijsje Dorman conducted a survey and summarized the attitudes towards kidney-related nomenclature for us at the beginning of the conference. And briefly, her survey revealed the prevailing attitudes of medical professionals emerging from a public review and a participant survey. And there appeared to be, even at the beginning of the conference, broad agreement with the goal of standardizing nomenclature, with the acknowledgement of challenges. There appeared to be qualified endorsement of replacing renal with kidney. There appeared to be widespread dissatisfaction with the term end stage as a descriptor of kidney disease. And there appeared to be recognition of the need for ongoing attention to nomenclature issues. So we felt that we had a supportive audience at the beginning of our conference. The KDIGO Conceptual Model of Kidney Disease is summarized on this slide, and I believe this should be familiar to all of you, with stages of kidney damage, decreased GFR, and kidney failure constituting kidney disease. With chronic kidney disease, these are precisely defined. With AKI, we're really dealing with this stage here with decreased glomerular filtration rate and kidney failure. The definition does not include markers of damage, although the definition of AKD includes markers of damage as well as these markers of AKI. And the KDIGO definitions of AKI, AKD, and CKD are schematically shown in this figure as well as in this table, where AKI is a disorder with a time course within 7 days, AKD of less than 3 months, CKD greater than 3 months. There may be episodes of AKI and AKD among people with CKD, so there is some overlap here. And of course, if a patient meets none of these criteria, they would have no known kidney disease, abbreviated here as NKD. The classification of kidney disease, as for all diseases, is based on structural abnormalities, functional abnormalities, outcomes, duration, and cause. And the staging of CKD and AKI that's been elaborated and accepted widely by KDIGO for CKD is that it's classified based on cause, GFR category, and albuminuria category, abbreviated CGA classification. And for AKI, it's staged according to severity. And it says in this AKI guideline that the cause should be determined whenever possible, although it's not part of the specific classification system. Of course, you're familiar with this heat map for the staging of CKD. with the GFR categories shown vertically and the albuminuria categories shown as a cross here, as well as the colors showing prognosis. And you're familiar with the 3 stages of AKI based on serum creatinine or urine output. So these were the definitions that we have been accepted, and we wanted to use terminology which was consistent with these definitions. Now, the following issues were considered to be out of scope. The classification of cause of disease. Of course, the International Classification of Disease is in its 11th revision, and the 12th revision is well underway, so we didn't want to duplicate that, although there can be many difficulties in implementing this classification in clinical practice. We did not talk about dialysis procedures, dialysis adequacy, performance measures, or outcome metrics. We didn't talk about dialysis vascular and peritoneal access procedures, performance measures, or outcome metrics. And we didn't talk about transplant procedures, performance measures, and outcome metrics. And of course, these are areas where future work will be needed. We also recognize that journal style will dictate when to abbreviate terms and may require alternative abbreviations to be consistent with schemes for other diseases. For example, serum and urine for use with concentrations, excretion rates, or ratios. So we did not attempt to standardize this. We thought the strengths of our consensus and our glossary that we'll go over in a few minutes is based on the existing KDIGO definitions, classifications, and nomenclature. It's based on a systematic process. We articulated a rationale and goals. We had a patient and attendee survey. We achieved attendee consensus. And we recognize that nomenclature standardization is a necessary step, but not the only step to improving communications. At the same time, there are limitations. The glossary is restricted to English, and nuances may be difficult to translate. It will certainly not be simply a matter of find and replace with a word processor. Although we had stakeholder participation, as Dr. Eckardt mentioned in the introduction, participation was limited by practicality. The glossary is not comprehensive. Several topics are out of scope, which I mentioned. And further specification may be required for some terms for studies in children where the definitions are not completely aligned. Nonetheless, we're really quite proud to have created this glossary. And in the following set of slides, I'll show you how the glossary is organized and go over some of the high points. So the left-hand column will be the preferred term. We will have suggested abbreviations. We have a rationale and an explanation, which I've really gone over today. So I'll spend less time going over that. And then we'll have terms to avoid. And as we pointed out early, agreement on a nomenclature involves compromise. And for all of us in this terms to avoid, there will be something that we'll miss. And it's necessary to understand that compromise means that nobody is completely satisfied. And in giving up some of these terms, we'll all think we're losing something. Hopefully what we gain is the package, and it will be worth it. Now, the glossary is divided into 5 parts to coincide with the 5 questions and answers that we had at the beginning. And so I'll go over them part by part. So part 1 is called kidney function and disease. The rationale is that the term kidney should be used preferentially when describing kidney disease and kidney function, with exceptions. And terms to avoid would be terms including renal, terms with a prefix nephro. But an exception here are the setting of specific functions, diseases, or syndromes as shown below. So for example, the term kidney disease would be preferred rather than renal disease or nephropathy, except in the setting of specific diseases such as membranous nephropathy would retain its name. Kidney function would be used instead of renal function, except when describing specific functions such as renal acidification, the renal concentration mechanism. Normal kidney function is a general term which should be easily understood. Abnormal kidney function would be preferred over renal or kidney impairment, insufficiency, dysfunction, or azotemia. Residual kidney function would be kidney function in people with kidney failure receiving kidney replacement therapy. And further specification would be required. Are we talking about urine flow rate or solute clearance? And if so, which solute? Although this term is usually used in the setting of dialysis, it could also be used to refer to native kidney function in kidney transplant recipients. And it would replace the term residual renal function. Kidney structure would replace the term renal structure, except when describing specific structures within the kidney. Normal kidney structure is self-evident. Abnormal kidney structure would be the opposite. Causes of kidney disease should be indicated wherever possible. The cause may be unknown, presumed, or known, and the method of ascertainment and attribution of cause should be described. Cause should not be inferred only from the presence of a comorbid condition, such as diabetes. Kidney disease in diabetes is not necessarily the same thing as diabetic kidney disease, and these terms should be precisely used. So that's part one. Part two is about kidney failure. And this may be the most broad-ranging of all the topics. It's defined in the KDIGO guidelines as GFR less than 15 ml per ml per minute per 1.73 meters squared, or treatment by dialysis, but further specification is required. Terms to avoid would be renal failure, end-stage renal disease, end-stage kidney disease, or end-stage or just renal disease, nephropathy, renal kidney impairment, insufficiency, dysfunction, azotemia. These terms are not as precise as this, and this would be the term to be used for that. The duration is important, and specification is required. For kidney failure, which is acute, a duration less than 3 months, we did not reach general agreement on a term other than acute kidney injury stage 3. There will be an update of the KDIGO AKI guideline in the coming months to year, and I think that they will deal with this term again. But for the moment, we have AKI stage 3 for disease duration less than 3 months, and it would take the place of these terms. For disease duration greater than 3 months, we preferred kidney failure. There was a brisk debate as to whether we should use acute and chronic kidney failure. And for a number of reasons, the term kidney failure was preferred for disease duration greater than 3 months. And it takes the place of all of these terms here. These terms are not precisely defined, whereas this would be a precise definition. Now, signs and symptoms are not routinely specified when talking about kidney failure. We view this as an area where there could be great improvement, and we would suggest specification is preferred, and the specification would be with, without, or unknown signs and symptoms, and with signs and symptoms would be synonymous with the term uremia. The uremia or the uremic syndrome is a syndrome consisting of symptoms and signs associated with kidney failure, and it does not indicate a causal role for urea. This was a term, an old term we decided to hold on to. Regarding treatment for kidney failure, we think it should be specified when writing about people with kidney failure. And the treatments are kidney replacement therapy, and this would include both dialysis and transplantation. And this would replace the term renal replacement therapy. Dialysis, for patients with kidney failure treated by dialysis, that would be AKI stage 3D, okay, or CKD category G5D. And that would replace these terms. The duration of the treatment could be long-term or short-term. Long-term refers to dialysis for chronic kidney disease, may also be referred to as maintenance dialysis. Short-term refers to dialysis for AKD and AKI, and that would replace chronic or acute dialysis. The terms acute and chronic refer to the duration of kidney disease rather than the duration of dialysis treatment. Of course, there's a tremendous variation in modality and frequency. We note the modalities here and we note the frequencies here, but we did not deal with the myriad abbreviations for different modalities and frequency of kidney replacement therapy. For kidney transplantation, we really have CKD category G1 and G5 and the T to indicate that patients have a transplant. And these are currently within the terms end-stage kidney disease, kidney failure, renal disease, renal failure, and we think that it really needs to be split out specifically to be more precise in referring to transplant recipients. And when referring to transplant recipients, we would like to specify the donor source, either deceased donor or living kidney donor transplantation. The general term for kidney failure with replacement therapy would replace the terms end stage, as I mentioned before. And there was a suggestion that we might use an abbreviation, kidney failure with replacement therapy. I would suggest that at this point, this is under discussion, but I think it certainly would be okay if people started using this term. I think it's preferable to these terms. We want to be sure that at no point do patients lose their eligibility for benefits under Medicare or other health insurances in which the term end-stage renal disease is present as part of the legal mandate, as it is in the United States. And we think this is an important point, so that when we talk about kidney failure with replacement therapy and writing up individual patients' claims, of course, we want to continue to use these terms end stage. Then we acknowledge that there can be kidney failure without replacement therapy. And this really depends on whether kidney failure is not chosen versus not available. Sometimes this has been called untreated kidney failure. We think this is inappropriate because there is comprehensive conservative care for kidney failure. This is different than no treatment, but further specification will need to evolve as the definition for this is evolving. And then there's without comprehensive conservative care. Moving on to part 3. I realize I'm going fast, but I want to leave time for your questions, and let me remind you to go ahead and write up your questions and insert them under the drop-down menu under questions, and we'll try to get to them. Part 3 is AKD and AKI. As I mentioned, this is disease duration less than 3 months. It's conceptually different from the initial recognition of CKD, although we recognize that we don't have any guidelines in place for how to define, classify, or take care of patients in that phase where we're trying to sort out whether it's acute or chronic. Terms to avoid are acute renal failure and acute renal insufficiency. Now, acute kidney disease, there is a KDIGO definition, which I've mentioned before. And acute kidney injury, of course, there's a KDIGO definition and a guideline. And AKI is a subcategory of AKD, right? A disease which evolves within 7 days, whereas AKD is a disease which lasts for less than 3 months. The AKI classification, we've gone over already, is staged according to creatinine and oliguria. And we would use this rather than previous classifications such as Rifle and Akin. I'll remind you that the 2011 KDIGO guideline harmonized these prior definitions into the current AKI definition. AKI stages, this is of course only applicable to people with AKI. And stage 1, stage 2, stage 3 are well defined. And now we'll turn to chronic kidney disease, which is the disease duration greater than 3 months. It would replace all of these terms here. The KDIGO definition is GFR or markers of kidney damage. The KDIGO CKD classification, as I mentioned before, is based on cause, GFR category, G1 through 5, and albuminuria category, A1 through 3. CKD without kidney replacement therapy would be the appropriate term as a general term for all these stages that don't require replacement therapy, and it would replace this alphabet soup of ill-defined and not systematically used terms here. The stages are different from the CKD risk categories, which are of course shown in the heat map, which I showed before. This would replace ill-defined terms such as mild, moderate, severe, early, and advanced CKD. And the risk categories, low risk refers to the green cells, moderate risk is the yellow cells, high risk is the orange cells, and very high risk are the red cells. So we often refer to stages, but we sometimes mean risk, and we should be clear when we're referring to stages and the categories that define them, or when we refer to risk. CKD progression refers to worsening GFR or albuminuria. Other biomarkers are not included because there's not yet consensus, nor is there consensus on specific terms to describe the timing, such as early, late, or the rate, such as fast or slow. And so we think specific terms should be defined in the methods of any paper that refers to progression of CKD. Further specification may be required. We're all familiar that GFR may decline during therapy for other conditions, which may not be considered as CKD progression, such as the initiation of ACE inhibitors or SGLT inhibitors. Similarly, CKD remission is the opposite of CKD progression, but is rarely defined, refers to improving GFR or albuminuria, and the criteria will depend on the disease. Use of specific terms should be defined in the methods. And the last part is the kidney measures. And this applies to people with or without kidney disease. And we must always be wary of measurement issues and variability. Methods need to be specified, and multiple measures may improve classification when there is variability. We have suggestions for glomerular filtration rate and clearance. We notice that these are not synonymous terms and should not be used synonymously. For GFR, the units must be specified, either mLs per minute indexed for body surface area, or mLs per minute not indexed. and they are not the same. Measured glomerular filtration rate, we prefer to see the abbreviation MGFR, and it would require specification of the clearance methods and the exogenous filtration markers. These should be noted in the methods. Estimated glomerular filtration rate, EGFR, the estimating equations and the filtration markers need to be noted separately in the methods without the assumption that one goes with the other. We suggest this abbreviation and format for the filtration markers. If we're talking about solute clearances, not with filtration markers, then we're referring to the clearance, and the solute must be defined and the units must be defined. Measured clearance using urea nitrogen, creatinine, or the combination, as we often do with quantifying residual or severely reduced GFR. Estimated clearance, this would be the terminology in the case, for example, of the Cockcroft-Gault equation. Estimated clearance, we would say the marker. The GFR categories, this is for use in describing GFR levels with or without kidney disease. The units are mLs per minute per 1.73 meters squared. And these are the categories used for the KDIGO classification. Hyperfiltration is a concept that is generally accepted but not consistently defined. If this term is used as an exposure, outcome, or covariate, the GFR threshold must be defined. GFR reserve is a term generally meaning the difference between stimulated and basal GFR, and we think this is a more appropriate term than renal function reserve. For albuminuria or proteinuria, the specific measurement conditions must be defined. And if we want to understand the concentration of non-albumin proteins, we need to clearly indicate the proteins that we mean. Albuminuria should be used rather than micro and macroalbuminuria. They're terms related to the concentration, the excretion rates of albumin or the albumin-creatinine ratio. For proteinuria, we have the same issues with concentration, excretion rates, and ratios with creatinine. We have categories for use in describing albuminuria or proteinuria level, irrespective of the presence or absence of kidney disease. These are the criteria for normal, mildly increased, normal to mildly increased are combined in KDIGO stage A1, moderately increased is A2, severely increased is A3, and nephrotic range or nephrotic syndrome is variably defined, and this is important to specify. We should not omit tubular function. Not all kidney function is glomerular function, and there's tubular secretion, tubular resorption, fractional excretions, fractional reabsorptions. So as you can see, we have a big list. These are the key take-home messages. Use kidney rather than renal or nephro. Use kidney failure with appropriate descriptions of the presence or absence of symptoms, signs, and treatment rather than end stage, since the latter term is not patient sensitive and connotes a stigma. Use the KDIGO definitions for AKI and AKD, for CKD, and specific kidney measures such as albuminuria or decreased GFR rather than general terms such as abnormal or reduced kidney function. So with that, I'll wrap up. We have 15 minutes for questions. I believe that Stacy and Nijsje will take your questions, and thank you very much for your attention thus far.
So thank you to Dr. Levey and Dr. Eckardt. They, as you've now heard from the conference co-chairs, there were also two editorial co-chairs, Stacy Christiansen and myself, Stacy with JAMA and I'm with AJKD. And we provided the editorial perspective and we'll be relaying your questions to Dr. Levey and Dr. Eckardt. There's one question here which essentially is pointing out that there have been decades, or not several years, that the CKD definitions have come out and various guidelines have come out, and there remains, confusion even between nephrologists. So I think the underlying question is, what is different about this effort? And perhaps Dr. Eckardt could speak to that. What do you feel will make this particular initiative maybe more successful than some of the efforts in the past?
I don't think I would agree that some of the efforts in the past were unsuccessful. This is a complicated process and it takes some time. And I think important steps were taken over the past years with all the different efforts spearheaded by KDIGO to come to definitions and to introduce a classification system actually based on what was previously established in the United States, bring it to a global level. And we felt that the time is ripe now to actually sum up. And as you have heard from Dr. Levey, the approach was pretty comprehensive. And what really differentiates it from previous meetings is that we organized this as a consensus conference, and so actually took votes on most of the details that you saw presented on these slides. And they didn't make it into the glossary and the conference report unless there was a great majority, at least, of the participants at this meeting that agreed to these terms and the nomenclature that was presented. That is unique. I don't think that everybody has ever taken a similar approach.
There was a question about whether the glossary and the files are going to be shared, and yes, they will be shared after the conference.
Okay. I'll take another question here. Perhaps again, Dr. Eckardt, there's been a couple of questions about the implications for other languages of this effort.
Well, that's a true challenge, and I can tell you, and we had some discussions already in my home country, in Germany, with, and we're planning by the end of the year to start a process where we will hopefully have a similar consensus process, starting with the KDIGO glossary, and see how we can best translate this into German. Currently, we have a mixture of traditional terms, some attempts to translate the terminology, and Anglicisms where we just take the English terms and use them embedded into German language. And I think we also need a similar process, and this is just for my country. I guess this is also needed for many other countries and languages.
There were a couple questions about insurance and ICD codes. For example, I don't know, Andy, if you're the best to answer this, but is there a new ICD code for AKD recommended?
Stacy, this is a good question. The ICD codes really have a completely different governance and structure. So I think we do not have an AKD entry in ICD 11 or ICD 12. They tend to, we do for CKD. I'm not sure that we do even for AKI regarding the staging. And there's really quite a long delay for implementation of these nomenclature changes into the ICD. it would be the eventual goal, but we recognize that we haven't gone that far, that complete distance yet. So I think that clinicians will need to use the ICD codes as best they can.
So again, to Dr. Levey, there's a question, are the terms KF, again, that would be kidney failure, and CKD G5 used interchangeably?
Well, Nijsje, you're also very familiar with this, and we spent a lot of time with this. Would that be correct? Is that, it seems to me that that is, that they are interchangeable. Is there a circumstance where you think they might not be?
I cannot think of one, so yeah, I think they could be.
There's a question, Andy or Kai, with respect to CKD with symptoms and signs, do we need to specify or list the various symptoms and signs?
This was a suggestion regarding further specification in the use of the term kidney failure. There, I think it would be really important to develop better tools for patient-reported signs and symptoms or physician-reported signs and symptoms, and to be able to specify which symptoms and signs are present or absent in order to conglomerate them into symptomatic or asymptomatic kidney failure. For the moment, we assume that people who've had dialysis and transplantation started must be sicker than people who've not. But of course, that's not necessarily true. Dialysis and transplantation may not be available, and the indications for initiating treatment are not precise. So it would be, I think, very helpful to be able to assess whether a patient has symptomatic kidney failure or does not have symptoms.
Okay, Dr. Levey, I have a follow-up question to the one that I asked previously. So this question is there a term that identifies a KF patient who is on dialysis, or does that have to be specified as CKD 5D?
You mean a term like a dialysis patient? In scientific publications, we are less and less categorizing patients by their disease or by their treatment. This is part of what some people would call patient-centeredness. We're now talking about people with kidney failure treated by dialysis. So I think that's probably the better way to refer to people.
There's a comment and a question that says, I welcome this attempt at standardization, but to be honest, it is pretty complicated, even for nephrologists. How are we going to sell these changes to non-nephrologists? And I'll just say my 2 cents is that as the chair of the AMA Manual of Style, we will be including a lot of the glossary in an update of the 11th edition. And we hope to do things like dual report. In other words, use the new language and the old language together. It's like this in all kinds of disciplines, genetics, cardiology. To introduce new nomenclature, you just kind of need to ease it in and just keep using it consistently, and then it will probably take hold. But I'm interested in Nijsje or Andy or Kai, if you have any other suggestions for implementing and, as it were, selling the new language.
I like the use of the term sell. I always like to sell high. I like to buy low. I think for people buying into this, this is not an easy buy-in. Although if we do it incrementally as you pointed out, Stacy, it will take hold. And this is the way it's taken hold in every other discipline within medicine. You know, there are 8 types of myocardial infarction that have specific definitions, and some definitions are appropriate for different uses of the term. And this was not an easy sell for the cardiology community to accept, but it required first a working group to standardize terms and then another group to keep on top of it. I think this will be the beginning of a big effort in nephrology to maintain and expand this standardization.
If I may, I would like to add that I would fully understand if people feel a bit overwhelmed now with once they have seen the glossary and all the different terms. But I would assume that if people take spend some time, take a closer look at it, it might well be possible that they don't consider this as complicated. I don't think it is that complicated. We try to be as consistent and logical as possible, and in some ways it is much simpler than what we are currently doing with using different terms that are not well defined.
And I would just add, I would encourage people to go to the KI conference report. It has supplementary material, including examples of text being edited in accordance with the glossary. So that, I think, really helps with visualization of what's actually being proposed. On the idea of examples, there's a little bit of pushback, it looks like, on kidney function and moving away from that. And Dr. Levey, I wondered if you could potentially give an example of when it would be appropriate to use the term kidney function, and maybe an instance where it would be better to use another term or a more precise term.
Well, you know, certainly when we talk to our patients, we routinely talk about kidney function, and we tell them that their kidney function is better or worse. And I appreciate the simplicity of being able to use a term like that. And I would, from my own point of view, that's actually hard for patients to understand. They don't necessarily know what I mean by kidney function. So I appreciate that we'll need to remain simple, and we'll need to explain these terms. At the same time, using kidney function as a routine synonym for GFR really is very imprecise. If we really mean that people, when writing and ascertaining severity of disease, I think we should not use kidney function to mean GFR. We should use GFR, and we should say, how was GFR assessed? Other kidney functions include, I mean, in general, they can be broken down into the excretory functions, of which GFR is one, and reabsorption and secretion are other excretory functions. There are endocrine functions of the kidney. There are metabolic functions of the kidney. And authors, scientific literature, should say what they mean. What did they ascertain? And they should describe the findings in terms of that. We have a myriad of terms used in scientific literature: worsening kidney function, improving kidney function, rapidly declining kidney function. People should actually say what they mean more precisely, so that we can have a better understanding of this.
It's 9 o'clock, I realize, but there was one last question that I wanted to address, and that is, do you have recommendations for how journals can and should implement these changes? You know, again, the idea about authors and others being resistant or surprised by new language. Then I wanted to point out that not only is there the very long and thorough full KI report, but a lot of journals will be publishing a summary. So the message will get out there, and journals who are embracing this should have additions to their instructions for authors. So they can always refer authors and peer reviewers to the new language and the resources that will support it.
Well, thank you very much to our other participants and to those of you who tuned in.